management of nystagmus. Infantile nystagmus. The aim of treatment in infantile nystagmus are to improve the visual acuity, to decrease the intensity of the nystagmus, thereby improving the appearance, to reduce any abnormal head posture, and to improve the appearance of any associated strabismus. This flowchart summarizes the nystagmus management. Let us go through it one at a time with improvement of visual acuity first. Refraction is the first step in improving the visual acuity. A cycloplegic refraction is often needed. Retinoscopy should be performed in the null zone. High levels of astigmatism are usually associated in infantile nystagmus. Doing proper refraction improves the visual appearance, performance, and visual awareness of the child. Contact lenses often give better results than spectacles in a child with an abnormal head posture. Let us see why. Contact lenses are better at correcting astigmatism. Also, the patient always looks through the optical center of the contact lens while wearing it, even if he has a presence of abnormal head posture. Since the vertex distance of the spectacles is eliminated in a contact lens, extra accommodation is needed which provides extra convergence. And this can significantly reduce the nystagmus, as convergence can dampen nystagmus in infantile nystagmus. A form of sensory feedback is also caused by the contact lenses, which causes the patient to be more aware of the intensity of his nystagmus. Next in visual acuity improvement is amblyopia management. Amblyopia is managed based on the type of amblyopia. Total occlusion can often worsen the nystagmus in case of latent and manifest latent nystagmuses. Therefore, in these cases, optical penalization and pharmacological treatment is better. How to diminish the intensity of the nystagmus? There are non-surgical ways and the surgical ways. Under non-surgical, we have medications, contact lenses that we have discussed just now, prisms, and Botox toxin. Pharmacological treatment. Many pharmacological agents like phenobarbital, sedatives, muscle relaxants like baclofen, and other GABA mimetics like gabapentin and memantine have been used, especially in the infantile nystagmus, to increase the foveation time. However, long-term usage of these results in side effect, and hence they are used only as a supportive treatment. Base-out prisms. The base-out prisms stimulate fusional convergence, and this convergence can dampen the nystagmus in infantile nystagmus. Therefore, the patient must have a binocular single vision and adequate fusional reserves to benefit from the use of the base-out prism. Also, patients who show significant reduction either in the intensity or head nodding with convergence can benefit from the surgical modality of treatment, that is the medial rectus recession. However, this treatment requires perseverance and motivation. Botulinum toxin is another non-surgical modality of treatment. It has been proved to be effective in dampening the oscillations of the acquired nystagmus, leading to the improvement in visual acuity and especially disturbing oscillopsia. But there are certain problems with Botox. The resultant muscle paralysis upsets the coordination and balance, and therefore the binocular single vision is sacrificed for improved monocular visual acuity. Ptosis and keratitis have been reported. Moreover, the results are temporary and repeated injections are required. The Botox can be given in two ways, either in selected extraocular muscles, in cases of nystagmus with horizontal waveforms like acquired pendular nystagmus, or it can be given in the retrobulbar space. This method is effective in nystagmus with vertical and mixed axis of movement, such as the oculopalatal myoclonus. This slide shows how to dilute Botox. Based on the vial use, either the 100 unit vial or the 200 unit vial, preservative-free normal saline is used. As the common dosage is 2.5 unit per 0.1 ml, 4 ml is used for diluting the 100 unit vial and 8 ml is used while using the 200 unit vial. Next, coming to the surgical management of the nystagmus. Currently, there are 4 surgical options available: the artificial divergence surgery, retroequatorial rectus muscle recession, rectus muscle anterior tenotomy, resect and recess procedures for the abnormal head posture. Artificial divergence surgery is based on the observation that many patients with congenital nystagmus show reduction in amplitude on convergence. So the aim of surgery is to induce a latent divergent ocular position which the patient will overcome using his fusional convergence and thereby dampening the nystagmus. So what do? We recess the both medial rectus muscles. The second procedure is retroequatorial recession of the horizontal recti. Principle: as most congenital nystagmus are horizontal in waveform, this procedure is designed to symmetrically weaken the horizontal rectus muscle and reduce the amplitude of the nystagmus. So what is done? All the four rectus muscle, horizontal recti muscle, are recessed around the equator of the globe. So medial rectus is recessed up to 10 mm and lateral rectus about 12 mm. The third surgery is horizontal four-muscle tenotomy. The principle is removing of a tendon organ which is responsible for proprioception abolishes the nystagmus. So what is done? Detachment and reattachment of the horizontal muscle at the same original position. The fourth surgical procedure is the resect and the recess procedure. It is also called the bilateral symmetrical repositioning of the eyes. It is used for nystagmus with abnormal head posture and eccentric null point. The principle of resect and recess procedures are: the eye is rotated symmetrically in the direction of the head turn, and thereby a relative gaze palsy will be produced towards the side where the eyes were previously directed. This results in centralization of the null point. Briefly about the history, Anderson first suggested recession of the horizontal recti muscle. Goto said, "Let us do only resection." Later, Kestenbaum came with the idea of operating all the four muscles and doing dissection and recession all at once. How much should we recess or resect was given by Park and Park's 5678 formula. Later, Calhoun, Harley, and Nelson augmented this formula. Goniometer is the instrument which is used to measure the abnormal head posture, and the amount of correction is given by the abnormal head posture. If abnormal head posture is less than 20 degrees, Park's formula 5678 is used. Whereas, if the abnormal head posture is from 21 degrees to 39 degrees, 20% augmentation of the Park's formula is done. When the AHP is more than 40 degrees, 40% augmentation of the Park's formula is done. Let us understand the Kestenbaum procedure with an example of right head turn. In this example, the patient has a right-sided head turn and the eyes are deviated towards the null point which is present in the left gaze. So we shall try to move the eyes towards the right side. For this, in the right eye, the LR resection and MR recession will be done, and in the left eye, MR resection and LR recession will be done, and this will be done according to the Park's formula. Now say if the patient has a chin-up position with the eyes deviated downwards in order to shift the null point up and correct the abnormal head posture, we will be doing a bilateral resection of the superior rectus and bilateral recession of the inferior rectus. Now this is an example of a patient who has right-sided head tilt. Therefore, the null point is shifted towards the left side and the eyes are also deviated towards the left side. Now to surgically maintain the eye in the direction of the tilt, that is towards the right side, we have to extort the right eye and intort the left eye. This is the principle of Kestenbaum procedure. So how do we surgically do that? The first picture shows the right head tilt in the same previous patient and the eyes are tilted towards the left side. And the second picture shows the horizontal rectus transposition. So in our patient, if we transpose the superior rectus nasally, this is the nose, okay, and inferior rectus temporally in the right eye, and in the left eye, if we transpose the superior rectus temporally and inferior rectus nasally, our eyes shall be redirected towards the direction of the head tilt, that is towards the right side. So summarizing the surgeries in infantile nystagmus, if the nystagmus dampens on convergence, an artificial divergence surgery is preferred. If there is a stable abnormal head posture with an eccentric null position, a Kestenbaum procedure is preferred. If neither of the previously mentioned two are there, four horizontal rectus muscle tenotomy or retroequatorial recession of the horizontal recti can be done. Of course, if an associated concomitant strabismus is present, the squint surgery can be combined with the nystagmus surgeries. Can we use prisms for treating the abnormal head posture? Yes, we can use the base out prism as mentioned before, or we can use the deviating prism which shift the image in the opposite direction to the head posture, that is towards the null point. Therefore, suppose in a right head posture and the null point is present on the left side, the apex will point towards the null point, that is on the left side. As the image is automatically shifted with the help of the deviating prism towards the null point, the patient will not have to move his head towards the right. In the end, treatment of all the underlying diseases should be taken care of. Lowering the dose or stopping the medication in cases of drug toxicity, medical treatment in multiple sclerosis, chemotherapy, radiotherapy, or surgery for brain tumors, surgical decompression in Arnold-Chiari malformations. These are my few references. Thank you for the patient listening. So thank you for the patient listening. Have a nice day.